Bismillahirrahmanirrahim. Assalamu alaikum warahmatullahi wabarakatuh. Today we are discussing hypertrophic pyloric stenosis. Hypertrophic pyloric stenosis is a condition in which muscles of the pylorus becomes thickened, leading to gastric outlet obstruction. Ultrasound is the diagnostic modality of choice due to its non-invasiveness, accuracy, and safety in infants. Normal measurements, we see muscle thickness of the pyloric region should be less than 3 millimeter, while anteroposterior diameter of the pyloric region should be less than 14 millimeter. Similarly, length of the pyloric canal should be less than 17 millimeter. In hypertrophic pyloric stenosis, we see the muscle thickness will be more than 3 millimeter or more than 3.5 millimeter. We usually measure this in transverse plane from inner mucosal layer to the outer muscle layer. Length of the pyloric canal should be more than 17 millimeter, and in some sources it is suggested that threshold is above 15 millimeter. There are few signs like cervix sign, the appearance of the pyloric canal as it elongates, resembling the shape of cervix on transverse images. We will see all these signs while discussing things on images. Target sign. This is seen on the transverse plane. Thickened hypoechoic dark muscle surrounds the echogenic bright canal, that is mucosa. And third one is the antral nipple sign, the protrusion of the pyloric mucosa into the gastric antrum, which is visible as an echogenic mound. Failure of the gastric emptying is observed in majority of the cases, but in few cases we can see that partial gastric emptying is noted. Technique of the ultrasound: the patient's preparation. Infant should be fasting for 2 to 4 hours if possible to ensure an empty stomach. Position of the infant: spine or in slight right lateral decapitous position to allow a better visualization. Probe selection: use a high frequency linear transducer with 7 to 12 megahertz frequency for optimal resolution in the infants. Scanning approach: begin in the transverse plane in the right upper quadrant. Identify liver as a landmark to locate the pylorus, which lies medial to the gallbladder and anterior to the right kidney. Rotate the probe longitudinally to measure the muscle thickness and length. Differential diagnosis: pylorospasm. Many cases mimics hypertrophic pyloric stenosis, but pylorospasm usually resolves with time, and it has a thinner pyloric muscle that is less than 3 millimeter muscle thickness. Gastroesophageal reflux disease, GERD. This may also present with the vomiting, but in the GERD there will be a normal muscle wall thickness in the pyloric region. Midgut volvulus, this is an important surgical emergency that needs to be ruled out if bilious vomiting is present. Clinical correlation commonly present in the infants between 2 and 8 weeks of the age. Symptoms include projectile, non-bilious vomiting. On palpation, we see olive in the abdomen, and infant is often dehydrated. Male infants are more commonly affected, 4:1 male to female ratio. Ultrasound provides both a definitive diagnosis and a way to exclude other causes of the vomiting in the infants, ensuring timely surgical intervention. Pyloromyotomy if HPS is confirmed. Here we see a few diagrams. This is the area of pylorus, longitudinal or sagittal view. This is axial or transverse view. Normal muscle thickness should be less than 3 millimeter. Normal diameter should be less than 14 millimeter or 13 millimeter. And pyloric canal or pyloric channel length should be less than 16 to 17 millimeter. This is the length. Here we see this is transverse or axial slice, and this is the longitudinal slice of the ultrasound. We can see this is liver, and here we see this is pyloric area. Echogenic portion indicates gastric contents, and this hypoechoic linear line represents normal thickness of the muscles of pyloric region, which is less than 3 millimeter. Here we see this is cross section through the pyloric region with the help of ultrasound. Central echogenic area is the combination of mucosa with gastric contents, and this surrounding hypoechoic area is basically pyloric muscle, which is of normal thickness, that is 3 millimeter, and the length of the pylorus is less than 16 to 17 millimeter. Similarly, the diameter is less than 13 to 14 millimeter. Another normal ultrasound picture where we can see this is opened pyloric channel, gastric contents are moving through it, and we see the wall thickness, that is the thickness of the muscle, is less than 3 millimeter. Here this is a collapsed portion where central echogenic area represent mucosa, while this area between two clippers represents normal thickness of the myometrium. Between these two clippers we measure the length, which should be less than 16 to 17 millimeter. So this is a normal measurement of the pyloric region. Here we see hypertrophic pyloric stenosis. These are few diagrams showing HPS. Usually the muscle thickness should be more than 3 millimeter. Diameter of the pyloric canal should be more than 13 to 14 millimeter, and length of the canal should be more than 16 to 17 millimeter. This is an example where we can see this is a cross section and this is the longitudinal view. We see this hypoechoic area represents thickened hypertrophic muscles of the pyloric wall, and this is echogenic or bright area represents collapsed lumen with the mucosa, and this is stomach. Here we can see this is the left lobe of the liver, and this one is gallbladder. Here we see this is liver, here we have gallbladder, and this is a donut shape appearance, a cross-sectional view of the pyloric region. This one is the echogenic mucosa, and this central portion, which is black, is the lumen, and surrounding hypoechoic thick wall is basically hypertrophic muscle in the pyloric region. So this represents hypertrophic pyloric stenosis on ultrasound. Once again, we will say that muscle thickness would be more than 3 millimeter, diameter would be more than 13 to 14 millimeter, and length would be more than 16 to 17 millimeter. Here we see another picture where muscle thickness can be noted both on transverse and longitudinal views, and this central portion represents bright mucosa and collapsed lumen, and this is the area where we can measure the muscle thickness more than 3 millimeter, length more than 16 to 17 millimeter, and overall diameter more than 13 to 14 millimeter. This picture represents a cervix sign. Area looks like a cervix when we do pelvic scan in the females. The appearance of the pyloric channel as it elongates, resembling the shape of cervix. Target sign, a donut sign. On transverse images, we see it gives a typical appearance of target lesion, or target sign, a donut lesion, or a donut sign. This is seen in the transverse plane. The thickened hypoechoic dark muscle surrounds the echogenic bright central mucosa. So this is bright mucosa, and this is thick hypoechoic muscle around mucosa. Another example of the target, a donut sign. Liver, gallbladder, this entire portion represents liver, and this is a cystic area which is gallbladder, and here you see relatively hypoechoic thick muscle in the pyloric region. Another sign is the antral nipple sign. This is a protrusion of the pyloric mucosa into gastric antrum, visible as an echogenic mound. So this tiny lobulated portion represents antral nipple sign. Another example of the antral nipple sign. Antral nipple sign. Gallbladder. This is pyloric region. Failure of the gastric emptying. Usually we see that gastric contents cannot pass through hypertrophic pyloric region, but in some cases we can see that there is evidence of partial emptying through hypertrophic pyloric stenotic area. And this is an example where we can see this is thick pyloric region, collapsed mucosa, and here we can see there is extension or passage of the gastric content through the lumen in hypertrophic pyloric region. And this is normal example where we can see bright mucosa which is showing associated gastric contents, and here we see normal wall thickness of the pyloric region, and this is liver. Repeat scan if symptoms persist. We have an example that we have a 10 days old patient who presented with an episode of the non-bilious vomiting. Sonogram shows a normal appearing pylorus. Repeat scan 12 days later done for persistence of the symptoms shows clearly a hypertrophic pylorus. This is seen over here. We can see there is thin walled pyloric region, This is a thin-walled pyloric area. Here we see liver, gallbladder. This is the area of the liver. And after 10 to 12 days, as the symptoms persist, scan was repeated, and we can see there is thick walled pyloric region. Muscles are grossly hypertrophied. Mucosa is bright and lumen is collapsed. And we can see this is hypertrophic pyloric stenosis in this region, gallbladder, liver. Take-home messages: in a baby who presents with the vomiting between the age of the 2 and 8 weeks, we should consider infantile hypertrophic stenosis of the pylorus. This should be considered as first diagnostic option. Normal ultrasound findings do not rule out infantile hypertrophic pyloric stenosis. If the symptom persists or worsens, it is necessary to repeat the study. Not all the cases of the infantile hypertrophic pyloric stenosis results in total obstruction. In some cases, gastric contents can be observed to pass through the pyloric canal. After surgery, the ultrasound findings do not return to normal for 6 to 8 weeks. Thank you very much. Assalamu alaikum warahmatullahi wabarakatuh.